In the neonatal intensive care unit, an infant's survival depends on immediate, complex interventions. There is no time to pause. Unlike other specialties, neonatologists cannot wait for a payer's prior authorization before beginning life-saving treatment. The care must happen the moment the patient arrives. While the medical response is immediate, the billing for these interventions is bound by rigid metrics based on birth weight and the time spent on care. A single day of documentation requires pinpoint accuracy across codes CPT 99468 through 99480. Selecting the right code depends entirely on birth weight, gestational age, and the specific level of intervention provided that day. Clinical urgency naturally outpaces administrative workflows in the NICU. Using standard billing methods in this environment leads directly to a broken revenue cycle. The impact is visible in the data. Standard healthcare claims face an initial denial rate of 11.8%. For neonatal intensive care units, that rate climbs above 18%. Missing procedure billing alone costs NICUs between 10 and 20% of potential revenue. Payers are becoming more restrictive. Between 2022 and 2024, the share of providers reporting an increase in denials jumped from 42% to 77%. In the context of a 60-day NICU stay, even minor daily errors compound. For a busy unit, these documentation gaps can mean tens of thousands lost every single month. When nearly 1 in 5 claims is rejected on the first submission, clinical success is being converted into a financial liability. These failures usually start at the billing desk. Generalist billers often lack the specialized training needed to capture the nuances of neonatal coding. This flowchart follows a 1,400-gram infant's claim. A generalist defaults to standard codes, missing the under 1,500-gram threshold. Second roadblock, missing ventilator settings triggers a medical necessity denial. Finally, NICU billing requires separate facility and professional claims. Generalists often fail to sync these. Payer variation adds a final layer of difficulty. Applying standard Medicare rules to a Medicaid or private insurer claim often leads to an automatic rejection. Standardizing NICU billing with generalist knowledge does not improve efficiency. It leads to higher denial rates. Finding and keeping a billing specialist who understands these specific coding rules is becoming more difficult. The current turnover rate for medical business operations staff is 33.3%. Replacing just one billing specialist costs a practice up to $30,000 when you account for recruiting, onboarding, and the productivity gap while the new hire learns the system. Even with a full staff, the workload is heavy. Practices spend an average of 13 hours per physician every week just managing prior authorizations. Critical NICU interventions, like central line placements or ventilation, require constant, time-consuming negotiation with insurance payers. Despite this massive time investment, more than 27% of these authorization requests are frequently or always denied. Practices pay premium salaries for staff hours that are consumed by retroactive paperwork. That time is lost to proactive revenue capture. The strategic alternative involves moving away from in-house generalists and towards specialized credentialed teams like Staffingly. This matrix shows the core trade-off. An in-house hire costs $75,000 yearly. The Staffingly model costs $399 weekly, securing AAPC and AHIMA-credentialed specialists, working exclusively on neonatal billing daily. This expertise is supported by AI. Smart routing prioritizes claims by value, payer type, and denial risk. Automated audits scan for coding errors before a claim is even submitted. Pairing dedicated human expertise with AI shifts the practice's cost-to-accuracy ratio. Practice managers often worry that outsourcing will disrupt their current workflow or lead to a loss of operational control. The implementation process follows a 14-day timeline. Staffingly connects directly to your existing EMR, including Epic, Athena, and Cerner, without using screen share delays. The integration is built on a compliance foundation that includes SOC 2 Type 2, ISO 27001, and HITRUS frameworks. Administrators receive a weekly KPI dashboard that tracks AR days and first-pass resolution rates with hard data. Specialty outsourcing provides objective, data-driven visibility into revenue health, removing the need for physical staff proximity. Practice administrators are choosing between the perceived control of an in-house team and the financial performance of a specialized model. Maintaining the status quo means absorbing high denial rates and the constant cost of staff turnover. These lines show the two paths. One accepts the 18% denial risk, the other targets an error rate below 1%. For specialized neonatal revenue cycles, credentialed outsourcing provides a level of consistency that in-house teams struggle to maintain. You can stop funding your own revenue leaks, initiate a risk-free 14-day pilot, and start capturing the revenue you have already earned.